Hello friends, welcome back to my channel. I'm making the third part of lower back pain. So we have already discussed acute lower back pain, what are the causes of chronic lower back pains, and one of the causes inflammatory one. And chronic means more than 12 weeks. So what is the cause of an inflammatory condition in patients come with the chronic lower back pain? Number one is ankylosing spondylitis. What is ankylosing spondylitis? So in brief, I would say in a young age woman, patients come with having pain in the lower back area, as well as the patient is having pain and stiffness in all the other parts of the body where there is a ligament insertion happens. I will be giving you some kind of sites where it happens. So in that situation, we call it the patient might be having ankylosing spondylitis. Sacroiliac or apophyseal joint pain will be present, and the patient will come with having destroyed articular cartilages that lead to pain and stiffness into the patient. Examination, decreased range of motion of the spines. Patient will not be able to do the same kind of spine movements. Tenderness will be present at the sacroiliac joint, which is, we call it at the side. Tenderness will be present at the tendon insertion. That I was talking about, ligamentum insertion, that is along the vertebrae and the hands and Achilles tendons. That means heel will become with these situations. So if scenario comes related to all of these kinds of things, then we might need to talk about that the patient is having ankylosing spondylitis. What is the brief tip I can give it to you? Inflammatory back pain is characterized by gradual onset of pain and stiffness that begins at a young age, that is less than 40, worsens with rest at night, and improve with activity. It suggests spondyloarthropathies, that means ankylosing spondylitis, psoriatic arthritis, reactive arthritis, arthritis associated with the inflammatory bowel diseases. All of these situations can come as an inflammatory back pain, and I was talking about AS. Now the second topic is spinal stenosis. This is one of the topic when patients could be coming with the age of 60 or above, because this is very common in those patients, and in these situations the symptoms will be same as a vascular claudication symptoms. But how do we differentiate between it is a vascular claudication or it is a neurogenic claudication? I will be giving you some of the tips to remember it. And that's why, because of having similarities with the claudications, we say this is spinal stenosis as a pseudo-claudications. So what are the symptoms we will see? Postural dependent pain, worse with ambulations. Patient will walk, they will say my pain is worse. Patient is not walking, it possibly, if they are bending their lumbar spine, they are feeling improvement in their pain. Just to give you a remember that the patients with inflammatory will say that their pain will improve with activities, but here their pain will improve with a flexion of the lumbar spine and worsen with activities like ambulations or extending their lumbar spine for any reasons. Lumbar extensions worsens pains. Let's suppose walking downhill will be increasing their pain, or just standing. So if a 60 years old woman is a cashier, the problem with their pain will be because she is standing long time. She cannot do that. Lumbar flexion improves the pain. How do we say lumbar flexion? That means they are bending towards front. Walking while bending forward, bicycling, shopping cart sign. That is one of the things which have been seen in patients, that when they are doing their shopping or they are going for groceries, when they are leaning forward onto the shopping cart, they feel good, they don't feel pain. This is a spinal stenosis. What are the lower extremities? Weakness, numbness or tingling, there will be present in these patients. Weakness will be present, numbness will be present, tingling will be present. lower back pain for sure. Pain radiates to the thighs and calf, could be possible. Straight leg raised chest will be negative here, because this is not radiculopathy. This is stenosis of the spines. No bowel or bladder movement will be symptoms will be present here. The only thing will be different is they having numbness, they having weakness, they might have radiation to the pain, but their straight leg raised test is negative, and when they are bending forward, they are having improvement in their pain. Examination: normal pulse will be present if you will check the dorsal peris or something. Normal overall examination, like reflexes will be normal. There will be no strengthening problems, or sometimes sensation could be normal. Diagnosis is, we do MRI of the spine because they are 60 or above. We don't know what's going on. We do the MRI and we find out it. Treatment is physical therapy and exercise. Surgical options are sometimes available but not always. What are the contributing factors to an spinal stenosis? Degenerative arthritis of the spine could be one of the contributing factors. Patient is already having osteoarthritis, that we call the spinal osteoarthritis. Degenerative disc diseases are there. The ligamentum flavum thickening or hypertrophy and bulging of intervertebral disc. That all leads to mechanical compressions and the narrowing of the cord, and leads to compression of the nerves, and that can lead to the pain, and that's why the pain goes on the back of the thigh and the calf muscles. So this is all about spinal stenosis. As I have already discussed, claudication word. So claudications means, most importantly, we talk about vascular. It is arterial or venous. But if we go down, I will tell you how do we distinguish. Always distinguish neurogenic claudications with the vascular in an older patients, because we all know that older patients usually have multiple risk factors for the atherosclerosis. They have hyperlipidemia, they are having any cardiac problems in the past, they are having any stent done in the past. We don't know, they are already having atherosclerotic risk factors. So it is possible that they are having vascular claudication. That's why they are having pain, or it is the neurogenic. How do we distinguish? The best symptoms, and then ABI, ankle brachial index. Let's talk about vascular a little bit. Vascular claudication pain is an exertional dependent pain. That means if they do exertional activities, the pain will increase. But the neurogenic was postural dependent pain. What kind of posture they are having, the pain will increase or decrease according to that. But in this situation, the pain will be decreased when they are having at rest. Lower extremities cramping or tightness could be present. No lower extremities weakness will be present here. Possible buttocks, thigh, calf or foot pain is possible. That's why I was saying there are many similarities between these two conditions. But here, if you will do ABI, definitely you will see decreased pulses, cool extremities, hair growth will be decreased, palar with the leg elevation. Diagnosis is ABI. If a patient is having symptoms like vascular claudication and they have a risk factors of having cardiac problems or hyperlipidemia or something, then we do ABI to make sure that this is not vascular. But if all of these things are negative, then we might talk about spinal stenosis, and let's see the patient needs MRI or no. And definitely shopping cart sign is kind of a one thing that definitely will help us to distinguish shopping cart sign. So this was all about claudication. It could be neurogenic or vascular. One tip which I would like to discuss here is this one. Lumbar spinal stenosis is the most common cause by degenerative changes in the spine and present with the lower back pain and the leg pain. The leg pain of the neurogenic claudication is the position dependent, exacerbated by the lumbar extension and persist even with standing still. Vascular claudication is an exertional dependent and resolves when with standing stills. That means they are not walking. If they don't walk, they are standing, they won't feel pain. But if they do walk, they will feel pain. And they will do rest, there will be no pain. So this is all about the distinguishing point between both of these. My next and the last topic of is vertebral column fractures. We call vertebral compression fractures. What are the etiologies? For sure, this is trauma. It's a fracture. Trauma is one of the important factors. But how a trauma happens to spinal cord? If there was a minor trauma, patient is osteoporotic, there is an osteomalacia, bone metastasis, metabolic like hypothyroidism, Pagets disease, or osteomyelitis, infections of the bone. So all of these situations in an old age patient can lead to vertebral compression fractures. What are the clinical features you will see? We don't know the patient is having acute or chronic. That's why both are having different kind of this symptoms. Acute back pain will be present and decrease spinal mobility. They cannot do the spinal mobility as they were doing before. Pain increases with standing, walking, lying on the back, referred pain to the abdomen or flank. Spinal tenderness at the affected level will be present. This is all present in acute situations. If you talk about chronic, painless, progressive kyphosis or loss of height. Loss of height is one of the factors. Complications, increased risk of future fractures. Increased risk of future fractures are very, very high. Hyperkyphosis, protuberant abdomen, early satiety and weight loss, decreased respiratory capacity. Patient with acute vertebral compression fractures present with back pain and decreased spinal mobility after bending, coughing, sneezing or lifting. They cannot do it. Common in more in women than 50, like those who have 50 years of the age, due to osteoporosis or systemic glucocorticoid injections. That means immunosuppressions. We always remember the age, we always remember the osteoporosis, but we have to remember it could be possible that the patient is taking steroids. For that reason, they are having high chances of getting vertebral compression fractures. How do we examine and what we find into the X-ray? So if you do the examination of the patients, you will find midline tenderness with percussion or palpation. No neurological deficit, because here our main target is patient is having issues with the compression. It's not related to the neurological deficit. Kyphosis or loss of height due to repetitive fractures. X-ray will show anterior wedge deformities. I would like you to highlight this X-ray, and if you see, the vertebral columns should be like this. They are always like this. There is no abnormalities in this. There is a good gap in between them. But compared to this one is little different. This is little different. That means they have having wedge shape anterior compression of L1. So this is showing us when the patient is having these types of changes into their X-rays, that means they might be coming with us with a pain as well as decreases spinal mobility. Even though they sleep, even they walk, even they stand, everything does not improve their pain. And the kyphosis will be present the more chronic the patient goes. This is all about back pains. I have uploaded 3 different videos on all the categories of the back pains. I hope you like it. If you have any questions, you can do a comment, and if you want to get this notes, I would be more than happy to share these notes with you. Just leave a comment. Thank you so much.